Well, good afternoon. This is Dave Ashkin. It's great to have everybody together here today, and we're really excited. Today we're going to be talking about World TB Day 2017. The numbers are in, and as you are aware, it's been 135 years since Robert Koch made his announcement that he had found the cause of tuberculosis, Mycobacterium tuberculosis. And that was really regarded as one of the big breakthroughs in infectious diseases. At that time, when Robert Koch made that decision, he noted that any disease that caused more than one-third of the world to be sick and die potentially of it had to be significant. And since 135 years, since that announcement, many, many things have happened. We've made advances, but unfortunately, as you know today, still, TB is still the leading cause of death from any single infectious agent. And as you know, if you think about how many webinars, how many lectures do you go to where you hear about diseases where you don't know what causes it, or if you know what causes it, you can't diagnose it. And even if you can diagnose it, there's no treatments, let alone cures. And even if there was treatment and cures, they're so expensive that nobody can afford it. And that's what frustrates us all, because TB is the exact opposite. TB should be the disease that should be the model. We know exactly what causes it. We know how to diagnose it. We not only have treatments, we have cures, and the cures are relatively inexpensive, and still more people are dying today. So today is a day where we observe World TB Day and observe exactly what TB still means to the world. It reminds us that we need to continue to pay attention. We need to still be vigilant. We need to educate, and we need to carry on the battle until it is finally won. One of the things that always struck me when I started in tuberculosis is March 24th, was a day we all it was weird, we're all together in the TB family and we're quote unquote observing World TB Day. For all of us, it's a day as bizarre as this is. We have together, that we all get together and we talk about what's going on in the world and what's going on in the United States. And the CDC has always led that. They, for over 25 years, have every year been publishing what the numbers were for tuberculosis the year before, and this year is no different. And we are so lucky to have our colleagues from the CDC here, both Christine and Zimi, to actually go over and announce the numbers of what TB looked like in 2016. And we also have some of our colleagues in our other states to talk about what's happening in their states and the trends they're seeing. So without further ado, I am so excited to introduce Christine Schmidt and Zimi Wansula from the CDC, who are going to be talking about the 2016 numbers. As you know, Christine is a second-year EIS officer with the CDC's Division of TB Elimination. She's board certified in both family medicine and preventive medicine. Prior to starting the EIS fellowship in July 2015, she practiced family medicine at a federally qualified health center in Washington, D.C. for a little over 2 years, and then in rural North Carolina for 4 years. So she is part of our Southeast region. And Zimi is a first-year EIS worker with the CDC's Division of TB Elimination, too. He's originally from Rwanda, where he completed medical school and training for general medicine. He came to the United States to pursue his MPH at the University of Arizona in 2012, and subsequently he returned to Rwanda and worked as a public health specialist with Partners in Health prior to returning to the States to begin the EIS fellowship in July 2016. Both Christine and Zimi just published, as you probably saw, the MMWR announcing the numbers, and they're here to present their data. So Christine, Zimi, thank you so much for being with us today. We're so excited.
Good afternoon, everyone. We are pleased to be able to present the Provisional 2016 National TB Surveillance System, or NTSS report. As you know, since 1993, U.S. tuberculosis or TB surveillance data for TB cases meeting the case definition from CDC and CSTE is reported to CDC. The report of verified case of TB, or RVCT, contains demographic, clinical, and risk factor data for TB cases in the United States. Data are maintained at CDC and are analyzed to inform TB control practices and programs. I was saying that the World TB Day MMWR is an annual report that summarizes provisional data for a subset of the RVCT variables, including demographic, clinical, and laboratory features. And for national origin, U.S. born is defined as persons born in the United States, U.S. island areas, or persons born elsewhere to a U.S. citizen. All other persons are considered foreign born, and cases are categorized by self-identify, race, ethnicity, as defined by the U.S. Census Bureau. The World TB Day MMWR also provides recommendations for potential public health actions. In addition to the data supplied by NTSS, incidence was calculated using data from the U.S. Census Bureau. July 1st mid-year population estimates are used for the denominator for overall incidence, and the current population survey provides population denominators for incidence according to national origin and race ethnicity. So in 2016, a total of 9,287 new TB cases were reported in the United States. This provisional count represents the lowest number of U.S. TB cases on record, with cases declining slightly from 2015 following the first annual increase reported since 1992. The 2016 TB incidence of 2.9 cases per 100,000 persons also decreased slightly compared to 2015. Incidence declined in both U.S.-born and foreign-born populations. However, the disparity in incidence among foreign-born versus U.S.-born remains high, with the incidence among foreign-born persons 13.7 times the incidence among U.S.-born persons. 18 states reported an increase in TB incidence from 2015 to 2016, which ranged from 0.7% in New York to 144.1% in North Dakota. Illinois reported no change in incidence. 31 states and D.C. reported declines in incidence, which range from 1.4% in Massachusetts to 75% in Wyoming. These larger percent changes should be interpreted with caution because they often represent small changes in case counts against the background of a small overall population. For example, for Wyoming, there was a decrease from 4 cases to 1 case, resulting in a 75% decline in incidence. In 2016, 12 states and D.C. reported an incidence higher than the national incidence. These states included Alaska, Arkansas, California, Florida, Georgia, Hawaii, Maryland, Minnesota, New Jersey, New York, North Dakota, and Texas. As in the previous 5 years, 4 states, California, Florida, New York, and Texas, reported more than 500 cases each in 2016. The combined total of cases from these states accounted for 50.9% of reported cases nationwide. Stratifying the data by national origin, there were 2,935 TB cases among U.S.-born. 284 of these cases were reported in persons aged less than 15 years, representing 9.7% of total cases among U.S.-born. The total case counts among U.S.-born persons correspond to an incidence of 1.1 cases per 100,000 and represent an 8.4% decrease from 2015. There were 6,307 TB cases among foreign-born. 103 of these cases were reported in persons aged less than 15 years, representing a total of 1.6% of total cases among foreign-born. The total case counts among foreign-born persons correspond to an incidence of 14.6 per 100,000 persons and represent a 3.2% decrease from 2015. The top 5 countries of origin for foreign-born TB cases did not change from 2015: Mexico, the Philippines, India, Vietnam, and China. Cases of persons born in these countries accounted for 55% of all cases among foreign-born persons in 2016. However, case count among persons from all these countries but India decreased from 2015. 136 other countries contributed to the other category, each accounting for less than 5% each of TB cases among foreign-born persons.
This chart depicts the national TB incidence, both overall and stratified by national origin during 2002 to 2016. The y-axis is number of cases per 100,000 persons, and plotted on a log scale to better show the trend. The U.S.-born incidence declined slightly compared to last year, as did the overall TB incidence in the United States. Foreign-born TB cases still constitute the majority of cases reported in the United States, nearly 68% in 2016, a proportion that continues to increase even though incidence in this population declines each year. Among U.S.-born persons over the past decade, declines in number of cases occurred among non-Hispanic blacks, non-Hispanic whites, and Hispanics, and remained relatively stable among other racial and ethnic groups. This table shows the number and incidence of TB cases among U.S.-born persons for 2013 through 2016 by race and ethnicity. TB incidence remained stable compared to 2015 among non-Hispanic whites and Asians, but decreased from 2015 in all other racial and ethnic groups. However, although the number of cases in each of these groups was small, certain racial and ethnic groups continued to be disproportionately affected, including American Indian and Alaska Natives and Native Hawaiian Pacific Islanders. Among foreign-born persons, the number of TB cases among Asian, non-Hispanic white, and non-Hispanic black populations has remained relatively stable over the 15 years. However, a notable decrease in TB cases among Hispanics was seen between 2007 to 2013. This table shows foreign-born TB cases and incidents for 2013 through 2016 by race and ethnicity. Asians have the highest incidence, followed by non-Hispanic blacks and Hispanics. Notably, incidence has increased among non-Hispanic whites and American Indian Alaska Natives. HIV status was known for 86.7% of TB cases reported in 2016. Among these cases, 5.8% had a positive result for HIV infection. As the graph to the right demonstrates, we have been successful in dramatically reducing the percent of TB cases co-infected with HIV, but progress has stalled, and the percentage actually increased slightly in 2016. Living in congregate settings such as shelters, long-term care facilities, and correctional facilities is a known risk factor for TB exposure, and greater than 93% of cases had complete data on these risk factors. Of these cases, 4.6% reported having experienced homelessness in the year preceding diagnosis. Additionally, 1.8% were reported as residing in a long-term care facility, and 3.5% were reported as confined in a correctional facility at the time of diagnosis. Drug susceptibility testing was reported for 98.7% of culture-confirmed TB cases in 2015, the most recent year for which complete drug susceptibility data are available. In 2015, there were 88 cases of multi-drug-resistant or MDR TB. Of culture-positive cases, 0.4% of cases among U.S.-born persons and 1.2% of cases among foreign-born persons were reported to be MDR TB. Of the 88 MDR TB cases, 81.8% occurred in persons with no reported prior history of TB disease or were primary MDR TB. In 2015, there was one case of extensively drug-resistant TB. Provisional data for 2016 demonstrates a slight decline in both TB case count and incidence in the United States compared to 2015. This indicates that the current TB control strategies are effective. However, the percentage of TB cases seen among U.S.-born persons less than 15 years of age, although lower than in 2015, indicates that transmission continues to occur in the U.S.-born population. This reinforces the need for continued efforts aimed at early identification of TB cases, prompt institution of appropriate treatment, and identification of exposed contacts to prevent a resurgence of TB. In addition, epidemiologic modeling suggests that maintaining similar rates of decline in the future will be insufficient to reach U.S. TB elimination in this century, and that identifying and treating persons with latent TB infection or LTBI is critical to accomplishing the goal of U.S. TB elimination. This strategy is in line with CDC recommendations as well as 2016 recommendations from the U.S. Preventive Services Task Force to screen for LTBI in populations that are at increased risk. The United States Preventive Services Task Force characterizes populations at increased risk as persons who were born in or formerly resided in countries with increased TB prevalence as defined by the World Health Organization, and persons who currently live in or have lived in high-risk congregate settings such as homeless shelters, correctional facilities, and long-term care facilities. Additional target populations include workers in congregate settings, contacts of someone with infectious TB, persons with immunosuppression, persons with other medical conditions associated with progression from LTBI to TB disease, and persons with fibrotic changes on chest radiographs suggestive of inactive TB disease. In summary, TB remains controlled in the United States. However, progress toward U.S. TB elimination has been slow. Epidemiologic modeling suggests U.S. TB elimination will be impossible to achieve in this century if progress continues at this slow rate. Therefore, new strategies are needed to decrease incidence and accelerate progress toward elimination. Expanding efforts to include targeted testing and treatment of LTBI in high-risk populations may make it possible to achieve this goal. We would like to acknowledge the other authors of the MMWR article, Bob Pratt, Sandy Price, and Adam Langer. We would also like to thank state, local, tribal, and territorial health department personnel for submitting data to the National Tuberculosis Surveillance System, and all of the members of the surveillance team and statistics and data management team for their tireless efforts in collecting the information which makes this report possible. Thank you so much.
Christine, Zimi, thank you so much. Interesting developments. I think what we've seen here, just to summarize, is that we've seen, which is good news, after last year where we saw a slight increase in the number of cases, the first increase that we had seen in over 20 years, 21 years, this year, again, it looks like we may be back on track, where we're starting to go down again, or at best, I think as was pointed out, these small variations, I mean, you have to be cautious about from a year-to-year standpoint, but it looks like we are kind of starting to smooth out and starting to hit those plateaus. We're starting to see that foreign-born individuals and with TB still predominate. We're interestingly enough starting to see a slight increase. Again, I think you got to be cautious about these small year-to-year variations, but in slight increase in the percent of cases with HIV. But also what I think is very important and has been pointed out is that while over 60% of the country has seen a continued decline, some states had an increase. And that's what we'd like to do now is go to some of our colleagues in our states around the Southeast and talk about what's happening. Personally, in Florida, we've been having some changes. Over the last 2 years, we have seen some increases, and we're seeing some changing in our population. And because of that, what I'm happy to say and very proud to say is that I'm going to introduce Tom Privet. Tom is our CDC Senior Public Health Advisor. He's currently serving as Florida's TB Controller. He started his public health career here in 1983 in Palm Beach until he left. I'm sorry. I always mess that up. I got to change that note there. He joined CDC in 1989. He was assigned to the TB program in Los Angeles twice and then served as TB controller in both Virginia and New Jersey. And we're really, really happy that Tom has come back to Florida. So I'm going to have Tom present the Florida data. So Tom, what's going on in Florida?
That's what I'm here to talk about. Good afternoon, everyone. With TB case counts in Florida dropped by 54% over the past 20 years. A historic low of 595 cases was reported in 2014, followed by 2 consecutive annual increases, totaling 44 cases or 7% by 2016. Despite this recent increase, the number of TB cases decreased by 6% over the last 4 years. Florida ranks 4th among the states in reported TB cases historically and in 2016 at 639 cases, behind California, Texas, and New York. TB case rate dropped by 66% over the past 20 years in Florida. Rate is defined as the number of TB cases per 100,000 population. The TB case rate increased to 3.2 per 100,000 provisionally. We don't have our year-end numbers yet as far as population goes. But that's from a historic low of 3.0 per 100,000 in both 2014 and 2015. Florida ranked 8th among the states in case rate in 2016, the same as in 2015. As you can see from this pie chart, most TB cases were reported in Black non-Hispanics, followed by Hispanics, white non-Hispanics, and Asians. Looking at race and ethnicity in general without breaking it down, foreign-born versus U.S.-born can cause you to miss quite a few things that you won't miss if you bother to do that. This slide illustrates the percentage of U.S. and foreign-born cases among various race and ethnic groups. Cases among the U.S.-born were divided about equally between white non-Hispanics and black non-Hispanics in Florida. For the first time historically, the number of U.S.-born TB cases reported among black non-Hispanics was less than among white non-Hispanics in Florida. Even though it was only one case, it's the first time it's ever happened in Florida, so it's worth mentioning. Cases among the foreign-born were predominantly Hispanic, followed by black, non-Hispanic, Asian, and white non-Hispanics. This slide presents the same data as the previous slide, but as the percent of total cases. In 2016, the majority of TB cases in Florida were among foreign-born Hispanics, followed by U.S.-born white non-Hispanics. Foreign-born and U.S.-born black non-Hispanics accounted for an equal percentage of total morbidity, followed closely by foreign-born Asians. With the exception of 2012, foreign-born Hispanics accounted for the highest percentage of cases, peaking in 2014 at 30.4%, but decreasing in both 2015 and 2016 when the number of TB cases increased statewide. Percentage of TB cases among foreign-born Asian population increased from 9.9 in 2012 to 15.6 in 2016, the highest percentage in the last 5 years. While all foreign-born population groups reported a higher percentage of total TB cases in 2016 than in 2012, all U.S.-born population groups, with the exception of Asians, have trended down over this 5-year period. Over the past 20 years, TB cases among the U.S.-born decreased by 75.1%, while TB cases among the foreign-born decreased by only 5.5%. 2015, the number of U.S.-born TB cases increased by 9.8% compared to a decrease of 4% in the number of foreign-born TB cases. However, in 2016, the number of foreign-born cases increased by 11.5%, while U.S.-born cases decreased by 1.6%. So there's no consistency in those 2 years where Florida saw consistent increases. Over the past 20 years, the percentage of overall TB cases in the foreign-born population increased from 30% to a high of 62% in both 2014 and 2016. Although TB in both populations has decreased over this 20-year period, the significantly greater decline in TB in the U.S.-born has resulted in this increased percentage of cases among the foreign-born. TB in the U.S.-born population, where a large proportion of TB cases are the result of recent infection, can be identified or prevented by traditional interventions such as contact investigation and treatment of LTBI. TB among the foreign-born is most commonly due to remote infection, usually in their country of origin, resulting in a reservoir of infection subject to future disease. The pie chart shows us that of the foreign-born cases reported in 2016, 54.4% were in the U.S. for at least 10 years, and a total of 67.7% had been here for at least 5 years. While traditional interventions are equally effective in preventing future disease in infected contacts, These investigations are only initiated after a new case is identified. The next best thing to prevention is the early identification of disease and initiation of effective treatment. The 10.3% of foreign-born TB cases diagnosed the same year as arrival in the U.S. is likely unpreventable even with an aggressive targeted testing and treatment effort in these new arrivals. Florida's investment in rapid diagnostic methods at its state lab and promotion of the expanded use of these technologies by private providers will assist in minimizing the spread of infection in the community. This slide shows the overall distribution of the countries of birth of foreign-born persons reported with TB in 2016, with the top 9 highlighted. 2016, the 9 top countries accounted for 71% of all foreign-born cases, with Haiti accounting for 23%. Persons from more than 49 other foreign countries each accounted for 2% or less of the total, but altogether accounted for 29% of foreign-born persons reported with TB in Florida. This is the slide I got out of order, so I'm going to skip it. As might have been predicted, the highest percentage of foreign-born TB cases in Florida were from the Caribbean. That includes Haiti, Cuba, and Puerto Rico. East Asia, Pacific, which includes the Philippines, Vietnam, and China, had the greatest increase from 2012 to 2016, an increase of 54%, making this region the second highest contributor to foreign-born TB cases in Florida in 2016. Most of Florida's TB cases were reported in the 45 to 64 year age group, followed by the 30% in the 25 to 44 year age group, and the 25% in the 65 plus year age group. TB cases in the 0 to 4 age group is minimal and generally identified in households during contact investigation. In fact, in Florida, about 8% of morbidity is identified as a result of a contact investigation. So our contact investigations have a very high case yield. Over the past 20 years, the percentage of HIV-infected TB cases has trended downward to 10% in 2016, despite the fact that the percentage of TB cases for which an HIV result is available has increased to 93.6% in 2016. The reason for the increase in TB cases in 2016 was not the result of risk factors that increased the likelihood of progression from LTBI to TB disease. In that year, the proportion of TB cases with the most common risk factors for disease dropped for all factors except HIV infection, which remained constant. Since 2009, trend lines are down for all risk factors except excess alcohol use. Despite the increase in TB cases in 2016, the proportion of cases with MDR-TB was down. The percentage of TB cases with INH-resistant disease was up slightly, but well below the 20-year highs shown in this graph. Keys to success in Florida. Number one, we must maintain our hospital contracts. Since the closure of A.G. Holly in 2012, Florida has contracted with 2 hospitals, Jackson Memorial Hospital in Miami and Shands Hospital in Jacksonville, to place our TB patients when they require hospitalization. Most of our admissions to these hospitals are voluntary, meaning they're medically necessary, and I think Dr. Ashkin deserves a lot of the credit because there are people who have been taken from hospice and placed in these contract hospitals and are living a fine life at this point in time. He really works with the staff there to make sure that we get a rapid diagnosis, that we also deal with any medical situation which is confounding the treatment of TB or making the individual who's hospitalized primarily for TB, we treat the whole person when they're in that hospital. And they come out much better for having TB in the first place than they would be had they not had a diagnosis of TB and that hospital been available to them. But these hospitals also provide the state with a contingency for court-ordered hospitalization when less restrictive means are not successful. We must sustain collaboration with our state TB lab. The TB lab in Jacksonville employs a testing algorithm that ensures that a PCR is performed on every specimen submitted, regardless of the smear result or the source. If positive for MTB, a Hain test, which is another molecular test, is done to identify mutations consistent with resistance to either INH or rifampin. Conventional drug susceptibility tests are on solid culture and based on minimum inhibitory concentrations of multiple first and second line drugs. The lab also provides quantiferon gold testing and collaborates with the state TB program in programmatic research to assess the impact of its testing on clinical practice. We must increase the use of nucleic acid amplification testing in the private sector. The Department of Health has developed guidelines for the use of PCR to assist in determining when the discontinuation of airborne infectious isolation may be safe, and we'll be distributing this guidance in the very near future through the Florida Professionals in Infection Control and the Florida Hospital Association to their membership. We must continue our support for County Health Department community-based care. From state fiscal year 2012 to 2013 to state fiscal year 2015 to 2016, funding support for community-based care increased by 6 times in Florida, from a low of just over $80,000 to almost $500,000 in the last state fiscal year. This has led to reduced costs associated with court-ordered hospitalization because those difficult to manage folks the CHDs now have the financial support that they need to manage those difficult cases in their communities. We need to improve the completion of therapy for LTBI. In 2011, Florida was 50 out of the 50 states for completion of therapy for LTBI in contacts. The bad news is we were 50 out of 50. The good news is there's no place to go but up. So we have a couple of strategies that we've implemented to help us improve those numbers, especially in contacts. We are encouraging the increased use of IGRIS over TSTs, and our results along those lines are up from the use of IGRA at 22.8% in 2012 to 41.5% in 2016. What that does is it reduces the LTBI caseload, and our data shows us that when the LTBI caseload related to contacts is lower, that leads to a higher percentage of contacts that are evaluated. What our data also shows us that the use of IGRA does increase the percentage of individuals willing to initiate treatment for LTBI. The second thing to improve these numbers is the increased use of short course therapy. The use of short course therapy in Florida is up from 23.4% in 2012, and this includes both regimens. It includes rifampin times 4 as well as 3HP. So we went from 23.4 in 2012 to 65.3% in 2016. And from 2009 to 2015, our completion rate for people on 9 months of isoniazid was 55.7%. Those on 4 months of rifampin completed at a rate of 69.3%, and those on 3HP completed at a rate of 71.6%, despite that in previous years 3HP was only used in the most difficult situations. So the data clearly suggests that expanding the use of short course therapy for LTBI should result in a higher treatment completion rate.
Thank you. Tom, thank you very, very much. Really exciting stuff. And what we'll do is, as we talked about before, is once we have our presentation, so I think we're going to open it up to questions. I think there was some very, very interesting things that you brought up that I think we'd like to discuss in a couple of minutes. Hey, just real quick, first of all, thank you guys for your chats, and continue, and please ask questions. And like I said, we will get to them. I know there's been a lot of requests for the slides. I realize that, you know, today is the day that, like, the CDC released it, and, you know, for many of our states, they're still trying to finalize the numbers. So at this point, unfortunately, we can't release all the slides yet and share them because we need to get the official clearance. But what I recommend, as you guys know, and it's always been, the CDC will release their, you know, slides, and each of the different states that are participating will probably add them to their website. So I think that may be the best place to go once they've all been cleared. But we really appreciate it, and we apologize for any inconvenience. But I think you would understand that we wanted to discuss these findings, and because of timing, we needed to you know, discuss them maybe before we had all the ability to get the clearance to distribute. But once we get those, we can share them, but not quite yet. All right. So if it's okay with you, we heard from Florida, and as you heard from Tom, we have again been experiencing for the last 2 years a slight increase in the number of cases. And next we're going to be hearing from North Carolina. And North Carolina also, for the last 2 years, again, the numbers, you got to be careful. The numbers are very small. But the trend is that we're definitely not necessarily seeing the same decreases everywhere, and in some areas we're starting to see a little bit of an increase. In North Carolina, like Florida, for the last 2 years, has also been seeing a slight increase. And we are very, very pleased and happy today to have Jenny Wheeler joining us. Jenny is the TB and HIV STD prevention epidemiologist for the state of North Carolina's Department of Health and Human Services Communicable Disease Branch. This is a role she's filled since September of 2015. She's worked in public health for the past 16 years, having previously served as North Carolina's HIV care epidemiologist as an HIV surveillance epidemiologist for the state of California. Jenny received a Master's of Public Health from the University of California at Berkeley in 2001 and a Bachelor of Science from the University of California in San Diego in 1998. And more recently, she's done doctoral work in epidemiology at the University of North Carolina, Chapel Hill. Jenny, we are so happy to have you today come and join us and discuss what you guys found in 2016 in North Carolina. Thank you so much, Jenny.
Thank you, Dave. Appreciate that introduction. So I am very pleased to talk with you about what has been happening with tuberculosis in North Carolina over the last year and looking back. As you can see from this slide, this is the last 20 years in North Carolina from 1997 through 2016. You can see we have observed a similar general trend to other states and to the national picture. We've seen a decline from previous highs, but we've seen a leveling out in the last few years. In 2016, North Carolina had 220 tuberculosis cases with a rate of 2.2 per 100,000 population, which was an increase of about 10% compared to 2015. Now that 2.2 rate, that is lower than the national average, which we are pleased with. But of course, the relative leveling off that we've seen in the last 5 years shows that there is still more work to be done. You can see in this slide, comparing 2012 through 2016, we have anywhere between 200 and 225 cases a year, and the rate is between 2 and 2.2 per 100,000. North Carolina, for those of you who are unfamiliar with our great state, North Carolina has about 100 counties. That's exactly 100 counties. And 85 of those have had at least one TB case sometime in the last 5 years. In 2016, 53 of our counties reported a TB case, at least one TB case. North Carolina's counties range from being urban to rural, and we have really wide differences. We have Having come from California, the mountains and the ocean are on the different sides, so we have mountains in our west and we have oceans to our east, and so we have differences between the state geographically, and the various counties have differences in population size. So that affects some of our year-to-year rates within the counties as well as the number of cases per county. So the top 5 counties in 2016 were Wake County, which is the Raleigh area, which is the state capital, the Mecklenburg County, which is the Charlotte area, and those are our 2 largest counties in terms of population as well. Guilford County, which is the Greensboro area, Robeson County, which is in the southeastern part of our state, and Durham County. And then there were several other counties that had smaller numbers as well. One thing to point out, you can see from the rates that are listed there, Robeson County has a higher rate than some of the other counties. We have some ongoing transmission in that area, and we have had just really dedicated local staff who have worked with that population, as well as we've received assistance from CDC and others. You can see here, these are the number of cases over the past 5 years in those top 5 counties. You can see it fluctuates year to year within each county, the number of cases they've seen. But again, Robeson has had more cases than might be expected, except we do know that they have sort of this ongoing transmission, and that's affected by, it's a very poor community, very poor area, very rural. They have issues with transportation. There have also been issues with folks completing latent treatment, and despite the Herculean efforts of those local health department staff, they don't always name every contact, which can be a challenge. So moving on, just some demographics of our population. Generally, about 60% of our cases are male. That's been fairly steady over the last 5 years. Our pediatric cases, it varies year to year, but generally we have more pediatric cases that are under age 5 years and fewer in the 5 to 14 year category, and it's roughly 5 to 7% of our cases each year have been pediatric cases. Looking at the risk factors, we have seen a slight increase in 2016 of our foreign-born cases, exactly like right at half of our cases in 2016 were foreign-born, and that represents a 16% increase in the number of foreign-born cases when compared to 2015, as compared to a 4% increase in the number of U.S.-born cases when compared to 2015. The top 5 countries for country of birth among our foreign-born cases are similar to what you see nationally. Mexico, India, Vietnam, and the Philippines. You can see it's pretty similar in 2016 as compared to the previous 5 years. The one difference is that North Carolina, Honduras is one of the larger countries of origin among our cases, and China is not, and that's a difference from the national picture. The HIV status of North Carolina's TB cases is fairly similar to that you see nationally, and fluctuates slightly from year to year, but it's 5% of the 2016 cases were HIV positive. We saw a slight decrease in 2016 of the portion of cases that had a documented history of a prior TB event. However, anecdotally, based on some conversations we had at our monthly staff meeting, this may not hold true. We're going to watch this. It may not be true for 2017. The proportion of cases with homelessness within the past year has also been pretty steady. 5.5% of our 2016 cases were homeless in the year prior to their diagnosis. We don't see much injection drug use among our cases. We see more non-injection drug use and excessive alcohol use, and the exact percentage varies from year to year, but it's typically 10 or 11% of our cases have documented non-injection drug use, and anywhere from 10 to 14% have documented excessive alcohol use. The one spike was in 2015 when we had 17% of cases with documented non-injection drug use. This might be due to marijuana use. That was what was mentioned by one of our counties as a non-injection drug of choice among their cases. And that spike may be due to some factors with that county. So just to summarize, we did see a 10% increase compared to 2015. Cases were more likely to be foreign-born and less likely to have a prior TB diagnosis. We did see an increase in the number of cases in our largest urban centers. But generally speaking, the trends in demographics and risk factors have been very similar to what we have seen in past years. I'd like to acknowledge my colleagues on the North Carolina TB Control Program, our nurse consultants, Myra Allen, Lynn Kearney, Julie Leffman, our TB registrar, Jeanette Green, Dr. Jean-Marie Maillard, and our TB medical director, Dr. Jason Stout, as well as the two of our colleagues who retired in 2016, Elizabeth Zarang and Ellen Fortenberry. I'd also like to thank all of our local health department colleagues, some of whom I have seen registering their attendance in the chat window, so thank you. As well as I'd like to thank our state lab, and I would like to thank SNTC, Emily, Donna, Dave, and everyone for having me. And in closing, I would just like to say, go Tar Heels. Thank you.
Hey, wait a second there. Jenny, thank you so much. That was fantastic. We really appreciate it. Thank you for doing this, and thank you for joining us today. And you can't go anywhere because we're going to be having some questions real soon. And again, I want to remind everybody, please, if you have any questions, I know we're getting some, and I have them all written down. We're ready to go in a little while. We'll be going over some questions for our participants so we could share our experiences. So please write them down, and we'll be going soon. So we've heard about two states where, like you've heard, there's been this kind of, I would say, plateauing or slowing down of the declines, both in Florida and North Carolina. And then we'd like to go to the other extreme and go to Tennessee, where for the last 2 years they've seen some very nice declines. And we are lucky enough to have Jason Cummings joining us today. And Jason, thank you so much. I hope we're not going to have to hear about any of the Tennessee basketball with everything going on. This could get a little ugly between the states. But Jason is currently the program manager and senior epidemiologist with the Tennessee TB Elimination Program. Prior to that, Jason was an epidemiologist with the Unified Government of Wyandotte County, Kansas City, Kansas. Currently, Jason is the Secretary of the Society for Epidemiology and TB Control within NCCA and is a member of several other national committees and work groups. He received his MPH degree from West Kentucky University in 2000. Look at this, Kentucky. I mean, this is really the whole Final 16 here. He received his degree in 2003, and he considers himself to be an all-around good guy. Hey, wait a second. Who put that in there, Jason? Was that you?
Dave, I didn't put that in there at all, but your check's in the mail for saying that, so.
Hey, Jason, how's everything going in Tennessee? Everything going good?
Things are good, and just to clarify, I'm not a Tennessee Volunteer fan. I am a big Kentucky Wildcat fan, so that's where my loyalties lie.
All right. So what's been going on in Tennessee with TB?
So I'm going to talk, as Dave mentioned, we're the odd man out in this series of presentations where we've actually had a decline. So I want to start by thanking SNTC for inviting me to present. I always welcome a chance to talk about what's going on in our state and the good work that's being done here. So in 2016, Tennessee recorded 103 cases. This is the lowest number that we've ever recorded as far as TB cases go. This represents a 21.4% decrease from 2015. So it's something we've really touted that we've had a large decrease compared to last year. As you can see from this graph, we've been, here in Tennessee, we've been below the national case rate since about 2009. Our case rate in 2016 was 1.5, which represented about a 24% decrease from the previous year. So I wanted to talk a little bit about what our 2016 cases look like and then compare them to previous years just so that you can see the trends going on over the past 5 years. So in 2016, the majority of our cases were greater than 25 years of age, which is not really surprising to us here in Tennessee. What remains a concern for us here is that last year about 5% of our cases were less than 15 years old. So this is something that we really push within our regions, always source case finding, and it's concerning when we have this many kids with TB. So it remains a top priority for us here in Tennessee to identify cases early and do large and efficient contact investigations so that we can find these cases and contacts. About 43% of our cases were African American. This outnumbered the other two races, white and Asian. Again, not a huge surprise here for us. But the percentage, while the numbers were lower all around with cases, the percentage of cases in Asians and African Americans increased in 2016. So the increase in the Asian population was about 20.3%, and in African Americans it was 14.4%. So we did have a larger proportion of our cases in 2016 that were of Asian descent. In 2016, most of our cases were not Hispanic or Latino. This is the trend that's always in the case here in Tennessee. It is a disproportionate trend between Hispanics and non-Hispanics. This has been the case since 2012 and even before that. So you can see the large disparity in percentage of our cases that are Hispanic versus non-Hispanic. Most of our cases were U.S. born in 2016, about 61% of them. And you can see that the trend over the past couple years, the gap was narrowing between the U.S. born and foreign born TB cases here in Tennessee. But in 2016, it widened a little bit and kind of wasn't consistent with what we had seen the previous 2 years, with the 61.2% being U.S. born. The most common country of birth of our TB cases as a whole was the United States, followed by the top two foreign countries of birth were Mexico at 7.8% and India at 6.8%. This is a little bit different the way that I presented this. I wanted to look at the TB population as a whole and not single out foreign born versus U.S. born, just to say this is the most common country of birth for our cases. I want to talk a little bit about some of the initiatives that we've had going on here in our state that we really feel like have increased our chances of eliminating TB and controlling TB. In the past 5 years, our Division of Laboratory Services have introduced the use of the Cepheid Gene Expert in 2012, and then in 2016 the MALDI-TOF. So both have helped one, identify TB quicker in specimens, and also with the Gene Expert has given a quick look at whether there's a mutation that's indicative of rifampin mutation. So both the introduction of both of these has helped us identify cases and then target and structure case management around the results of these tests. We really try to target, in the past couple of years, as you'll see, our efforts to identify and treat patients with TB infection, beginning with the use of QuantiFERON Gold as our primary test for TB infection in 2013, and most recently, beginning in January, a change to the reportable disease list here in Tennessee that makes positive tests for TB infection reportable. So talking about the QFTs that were introduced in 2013, we're fortunate enough that our state lab is able to run this test in-house. So these specimens are collected at our local and regional health departments and are couriered to our state lab for analysis. So the positivity rate of QFTs has been steady between 10 and 12%, but one of the things that we're most proud of when it comes to our QFT draws is that our indeterminate rate since its inception in 2013 has remained less than 1%. It normally ranges about 0.4, 0.5%, so that's a real testament to our folks out in the field that are drawing this blood and that are shipping and handling these specimens. So anytime that we get a chance to talk about our low indeterminate rate, we like to brag about that and about our folks that are drawing the blood. We implemented the short course 3-HP regimen for TB infection in 2015. We experienced a relatively slow uptake of the use of the regimen in 2015, but we saw its use dramatically increase in 2016. So our data show that in 2016, about 71.9% completed treatment, completed the 3-HP regimen, and 5.9% stopped due to an adverse event, and 12.2% stopped due to another reason. Either patient was lost to follow-up, the patient just decided to stop, there was a provider decision to stop, or something of that nature. In 2015, we partnered, the TB program here in the state partnered with our Tennessee Department of Health HIV/STD program and the Tennessee Department of Correction to implement a screening for TB infection, HIV, syphilis, chlamydia, and gonorrhea for all prisoners at intake in 2 of the intake facilities here in Tennessee, a male intake facility and a female intake facility. This was a big project, and it's something that we're really proud of because before the prisons were doing testing and shipping specimens outside of the state, and now with this project they're able to collect all of these specimens and they're couriered to our state lab for testing. So this was a big volume increase for our state lab, and we're very pleased and proud that they were able to accommodate this. The positivity rate at the men's intake prison has remained about 5% since the inception of the project, and about 3.5% in the women's intake facility. So this is a partnership that we're very proud of, and that has been very successful so far. I mentioned in January of 2017, we made a change to our reportable disease list that includes positive tests for TB infection. So the following change was made. Positive skin tests are now reportable in patients less than 18 years of age, and all positive IGRA tests, that's quantiferon gold, N-tube, or T-spot positives, are reportable for patients of any age. So what we wanted to do with this was we already kind of had an idea of the volume that were being tested at our local and regional health departments. So we really wanted to see how much testing was going on out in the private sector. So the first part of this project for the first couple of months is really just a fact-finding mission to see the providers, the private providers that are doing high volumes of these tests, so that we can target education, reach out, and develop partnerships with these providers. Here at the state, we've been recording TBI surveillance data in our state surveillance system for all patients that are diagnosed with TB infection at our local health departments since 2013. So TBI surveillance isn't something that's new on the state level. It's just been limited thus far to patients that have only been seen at our local health departments and have been diagnosed with TB infection at our local health departments. So since 2013, our case rate for patients with TB infection has averaged about 18.4 cases per 100,000. The caveat there is, again, that it's just patients seen at our local health departments, fully evaluated there, and diagnosed with TBI. And whether or not they start on treatment is not, they don't have to be started on treatment to be recorded in our state surveillance system. So this is something that that's new for us, the new venture of adding private providers to our surveillance data to see what's going on there, and the numbers, seeing how our numbers change once this is added. So these are just some initiatives that we've been proud of and that we feel are getting us on the road to TB elimination and control in the state of Tennessee. Now, the opposite side of that is that so far this year we're up 125%. So we have 27 cases as of the end of last week compared to 12 at the same time last year. So we haven't really delved into looking at what's causing this increase. If the trend keeps going, it's going to be more similar to some years past, and 2016 will stand out as the anomaly of case counts. So with that, I'm going to turn it back over to Dave, and I guess we can do questions whenever.
Yeah, Jason, thank you very, very much. I mean, I can't thank you enough. And so what you saw just, for over the last hour, what you've seen is an interesting, presentations. One starting from the national level and what's happening nationally, and then trying to hone down more locally. And you can see one of the things that I think, obviously makes this nation great is its diversity, and what you're looking at is the differences. We're looking at congregate data, and then coming back and looking how each different state has some different challenges and different demographics, and how we're each adapting. And that's what I'd like to do over the next 20 minutes, is kind of talk about some different issues that were discussed today. And I got some of your questions, and please, again, if you have a question, we'd really appreciate it if you just put it either into the Q&A or the chat. Though I have to say right now, the chat is really more filled with NCAA basketball right now. But if you have a question, please ask. So if it's okay, I'd like to start with the national data first, if that's okay with you guys. And so, let's start first with, some of the things we heard from the presentation of the MMWR stuff from Christine and Zimmy. And, what we're looking at, again, I think we'd agree, is luckily we're back on track. We're having a slight decline. But again, it looks like nationally, the predominance, again, of TB among individuals who are foreign-born. And, one of the things that, just to start the conversation, we kind of heard a couple, Jason talk about and stuff, is that one of the things I find kind of interesting, is, obviously, when you look at the nation, the countries that, we see a lot of our cases coming from, and then obviously locally how it changes, but also the difference in children. Christine, I think you touched upon it. It's kind of interesting, even though it's gone down a little, it is interesting that, 10% of all U.S.-born cases were among kids less than 15 years old, and then yet among foreign-born, actually much less. Any clues, and then we'll open it up to all the panelists, but any clues, or why do you think that may be happening? Zimmy, Christine, or anybody else?
Can you hear me?
Yes, Christine, go ahead, please.
Okay, great. So what we do know is that, among foreign-born across the board, the vast majority of cases are due to reactivation. And so we are seeing more recent transmission in the U.S.-born population than in the foreign-born population. And one of the things that our genotyping team has been able to do is develop more refined algorithms to really analyze when there are clusters, whether or not these clusters are due to recent transmission. So I think that's going to be really helpful going forward for the states to really be able to better characterize when they do have clusters come up, whether or not this represents reactivation or recent transmission. And so I think that's going to be one of the key strategies for really trying to address what we see as ongoing recent transmission among the U.S.-born population.
I totally agree, and I think we, traditionally, especially young children, we always use them as the quote-unquote, and they always represent kind of the canary in the coal mine, that they are, indicative usually of recent transmission. And I think this really gets back to Tom's point, and something we've always known, the importance of contact investigations. But I think also emphasizing the point that when we're doing a contact investigation, really making sure we find those individuals who may be most vulnerable, especially children, immunosuppressed individuals. Because, while the number of cases among U.S.-born is going down, it really does show that among U.S.-born there's evidence that recent transmission may be much more of a factor than among foreign-born, as Christine, as you pointed out so well, that where reactivation may be more of the issue. Tom, any comments on that, especially like you were saying before about the yield of contact investigation in Florida? That's pound on 6 to unmute.
It was cycling for me. I think that there's always a lot of effort that goes into contact investigation, a lot of time, a lot of energy, a lot of expense, a lot of investigation, and without that initiation and completion of treatment, it's all for naught, except if you do identify cases in households, especially U.S.-born households, or foreign-born households with U.S.-born children, and like I said during my presentation, we see about 8% of our cases identified as a result of contact investigation, but there's so much more that can be done if you're successful with the initiation and completion of treatment for LTBI. And that's the only way we're ever truly going to get the value that we should out of contact investigation.
So so Tom, you're 100% right, and I'm going to switch a little and then get back, but there's a ton of questions about how people are doing EDOT and where are they using it for LTBI and what regimens, because one of the things that the MMWR really stressed, and I think it's something we all feel, and it's based on a lot of modelings that Ken did back, I guess, 4 years. Ken Castro did about 4 or 5 years ago, which showed that, unless we really make a major change, we will not, with these declines we're seeing, we will not see the elimination of TB in the United States. And again, elimination being, as it always has been defined, as 1 case per million population. So, just for a second to go, you're exactly right. I mean, we talk a lot about, screening for LTBI, and we talk about contact investigation, reporting of LTBI, which I think I'd really like to maybe also touch upon. But I think the key comes down to it really is not very, very helpful if we do all these detection of LTBI if we don't make sure that people complete the therapy. And I guess I want to, go to a couple of questions that we got about LTBI from like Marlene Ayers and others, asking about, and it was touched upon by Jason. Jason, if I'm correct, you said that in Tennessee about 6% of people you started on 3HP, they actually stopped because of adverse effects, and then another 12% stopped for other reasons, which means that about 80% of the individuals, if I'm correct, more or less who started on 3HP completed. Is that more or less correct from what I heard?
That's correct. We had about 72% in 2016 that completed treatment, and the adverse events we haven't done an extensive analysis of those, but they weren't anything big. They were more, some headache, a little nausea, things like that. So it was just enough that the patient didn't want to complete anymore. But yeah, it's been successful here in Tennessee and has been more convenient for patients and for our health departments that our policy is written that they deliver the first dose of all of our 3-HP doses are done via DOT. They deliver the first dose in the health department setting, and then the remainder of the doses can be delivered at a home, work, or in a field setting somewhere.
Interesting. And are you using some of the questions are being asked? And again, I know we'll go back and forth a little, but are you doing, when you say by DOT, are you using also eDOT or video DOT or any other form of DOT, or is it straight face-to-face DOT?
So I'm sorry, I forgot to mention that on my slide as one of our new initiatives. We've just put out our electronic DOT or eDOT policy when we revised our TB manual this year. So far it's been used primarily electronic DOT for cases where the applications that have been approved by legal here in the state to use are VC, which is an app for both Android and iPhone, or FaceTime. So our legal department looked at various other methods or programs and decided that those weren't HIPAA compliant for what we were looking for. So those are the two approved. It's primarily been for cases, but we have used it a couple of times for 3-HP doses, and it's been very successful. The patients have liked it, and the staff, it's easier on them. In the past, we had used this as an alternative option for special situations where it was difficult for a patient to come in, or they were a truck driver and on the road. But now we're moving towards the not as a last resort, but as an option that's on the table from the beginning if the patient qualifies for eDOT.
Great, Jason. Thank you. And Jenny, any comments on you using short course LTBI therapy at all in North Carolina?
We are. We actually encourage our counties if it's feasible for them, but it's of course a decision that's made, I think, at the county level and based on the patients. We've had success with short course regimens, and that's something that we encourage, particularly in places where we aren't seeing really high completion rates for LTBI treatment completion. And then in respect to the DOT question, because I'm sure that's going to be your next question, DOT is required for all TB cases of active TB disease in North Carolina for their treatment, and we do have a policy about video DOT, and some of our areas are using it. We're actually talking about ways that we might use video or electronic DOT. We might increase the use of that as we look at how we are going to incorporate the recent treatment guidelines into our state policies, because the recent treatment guidelines call for more frequent dosing than what we have been doing.
Yeah, I mean, again, and it's the reason we're asking these questions. It's interesting. I think all of us are going through it, and that's a lot of these questions we're getting are really talk about, okay, we know we need to take the next steps, but how's the best way to implement it? And I think all of us are finding what we call DOT extenders, to be helpful, and also making sure not just start the process of testing, but also making sure that we complete the process by making sure people complete. Tom, I mean, we've been doing 3-HP down here for a little while, as well as rifampin, and you talked about these completion rates. Are you aware, Tom? I mean, and I think what the other thing is it working? I mean, and to the best of my knowledge, there's been very few, like none, and again, it's way too early, of failures of 3-HP. I mean, most of the times we see a failure, if I'm correct, is usually because of somebody who didn't complete, but just preliminarily and off, and kind of off the cuff. But Tom, not only are we seeing higher success rates as far as completion, I don't think we're hearing too much about failures. And again, I'm not saying there has been none, but it seems like so far, and yet it's too early, it's been somewhat successful. Do you agree with that, Tom? And any comment?
I mean, in looking at it, its use in Florida from 2012 through 2015, 71.6% completion rate, and for most of those years, we were only using 3HP in populations such as people in county jails, migrant workers, just the homeless. So primarily in the worst populations, and even though that was the only place where 3HP was being used, the completion rate was still higher for that than for, even though the numbers that were on 3HP were lower, the completion rate was higher than either rifampin times 4 or INH times 9, and the denominator was huge in at least the INH population.
I think what we're all hoping to see is if in the next couple of years, if we continue, if these impacts and these investments we're making in public health to try to prevent TB pay off, because I think it's been very, very frustrating for all of us in the past when we had to rely on 9 months of INH to get somebody to complete it, and these are exciting. Hey, Jason, just, while we're going through, you mentioned something that kind of intrigued us and intrigued me, and I've seen some questions. You said that you start the 3HP in the clinic. How have you dealt with that as far as like nurse issuance, like being able to have the drugs in the clinic? Like, because I'm sure not all your clinics have pharmacies. As a matter of fact, if you're anything like us, most of ours do not. So are you keeping the drugs in the actual clinics in order to dispense them?
So you're correct. So our regional health departments, where our TB clinics are, have a certain amount of 3HP available, and if for some reason they have a patient that needs to start and they don't have the medication, we can either move some around the state or drop ship it. So it is available on hand for patients when they're can start right then.
And, exactly, that's been that's where we've had to do our policies, and I think all of us have had to work out exactly that. Hey, getting back to the national for a second, so Christine and Zimi, one of the things that is clear is that luckily, again, we're seeing a decline, but as been stated by, in the MMWR, the concern that this decline is not enough. Just a little background. Zimi and Christine, when you were writing that, what was some of the concerns you had about, the extent of the decline, and what was the thoughts behind maybe what would have to happen in order to accelerate the decline?
Oh, you can hear me?
Yes, we can now. Sorry about that.
Okay. Oh, that's okay. So we were using some of the modeling done by Andrew Hill and colleagues, and I think you mentioned Ken Castro, and I think he was part of that group. So that was published a few years ago, and they looked at various scenarios of different ways that we could try and reduce incidence of TB in the United States. And one of them was to improve treatment rates. One of them was to identify and treat LTBI. One of them was to try and reduce actual immigration into the United States. And the only intervention that they saw making any significant difference was identifying and treating LTBI. The treatment rates that we are currently at are so high that any additional improvement would be so incremental that it wouldn't really make any significant difference. And then likewise, when they did some modeling to see if decreasing numbers of immigrants into the United States would make a difference, that it was, again, very, incrementally small, any difference that would make. So they really focused on this identifying and treating LTBI was really the key to accelerating progress towards U.S. TB elimination.
Go ahead, please.
Maybe another thing that I just wanted to add, as you all saw, there was a companion article that also showed that most of the TB cases that we have among foreign-born, we have more than 50% of them have been here for more than 10 years. So it's very important then to focus on also those people so that to treat LTBI because if we don't identify and treat those people with LTBI who are infected with LTBI, we will not be able to reach elimination.
Yeah, I'm really glad you brought that up because, that really, that second companion article is something that we've been looking at and it's really intrigued us. As many of the individuals on this call know that we really changed our overseas screening over the last 10 years, and I think we've really, come up with it, and when I say we, I mean the CDC and others partnering with with different nations have come up with a much stronger overseas screening, and I think in part, and Christine and Zidney, I wonder how you feel, and then I'm going to turn it over to Tom for a second because we looked at it. But I think that one of the reasons we're seeing less individuals who are diagnosed within 2 years, I think we're doing a better job screening overseas. Christine and Zidney, do you want to comment on that? And then Tom, I'd like to hear, I know you recently looked at this and just to talk about it, but any comment, Christine and Zidney, on that?
Yeah, Dave, I think you're absolutely right. I think adding the culture to the screening, the pre-immigration screening process was key in really reducing the number of cases of TB that were actually imported to the United States and that were diagnosed in that first 2 years after arrival.
Right, so I think we've done a really good job now screening out people with active TB, but as Zinni pointed out, it's not going to go far enough unless we make sure those people who are infected get treated, so this way we don't see it later on, possible at all times. I know we just quickly were talking about this on a recent call, and what did we find in Florida? I thought it was very interesting.
Well, are you referring to the time in the country prior to diagnosis?
Yeah, I mean, we were looking at, if I'm correct, Tom, we looked at those people who were diagnosed within 2 years, and I think what we found was, interestingly enough, and again, it wasn't large numbers, but I believe like of approximately 8 to 10 cases that we found of people who were diagnosed within the last, within 2 years of coming in over the last 2 years, I think we found that the vast majority, interestingly enough, were culture negative, and they were just clinical cases of TB that we decided to retreat. I think there was only one positive culture, and I think that was a case, if I'm correct, where the person also had NTM that may have interfered with the culture results. But I'll let you make sure that I was correct on those numbers.
I do remember that. I believe it was Lori, though, that ran the analysis.
Correct.
But it was, yeah. I can remember back prior to 2009 that taking care of your recent arrivals on EDN was an excellent case-finding activity. It is not a very good case-finding activity at this point, and that's a very good thing.
Right, I think that's a real credit to our panel physicians overseas, and as Christina pointed out, including cultures. And the other thing I would like to say is I think it's important also that we take a look at those people who are being diagnosed within 2 years. I think you'll find that many of them are quote-unquote clinical cases or culture-negative cases that we're just deciding to retreat or to be on the safe side. And obviously, I think another thing, and that's a whole other discussion, but I think the use of PCR in these cases may be somewhat confusing because some of them may be PCR positive, but that's because they've had previous treatment and subsequently turned out to be culture negative. But I think those are issues I think we're all dealing with. Jason, and just real briefly, or Jenny, any comments on that, or else what I'd like to do is just finish up with one last point.
Dave?
Yes.
I would like to say that when we did a program evaluation in the Tampa area, almost 75% of their refugees that were referred over the TB clinic because they had a positive test for LTBI had abnormal films. So it's not surprising that we're getting a lot of clinical diagnosis out of that particular group.
You're totally right. Abnormal films, and then they have a positive, usually IGRA or PPD. So what I'd like to do is just one more point, and then I can't thank you guys enough. So we heard before that we need to take extra efforts. We're going to need to step up our efforts for targeted testing. And one of the things I thought was very interesting was Jason's comment on that the state of Tennessee now is going to be reporting, LTBI, and I think a lot of states are starting to look at that and consider it. And Jason, I guess I was going to ask you just for a comment that I take it what you're looking for is you're hoping that by making LTBI potentially a reportable disease, it may bring more attention and maybe increase the awareness of LTBI among physicians especially, which has always been a challenge. I know Dr. Rivera, I saw one of her questions is, how do we go about and make physicians more aware of the importance of screening for TB, and then obviously the most important is starting on therapy and completing. So Jason, some of the thought process that's behind making LTBI reportable.
So you're correct, Dave. So it's actually a 2-for-1. That yes, we hope that it will become on the radar more and more aware. We also hope that it will allow us to develop these partnerships with these providers. And as our cases have decreased, an increased focus on these people with TB infection as those are our next cases. So that's kind of the idea behind this. I will say that as much as I can say, it was driven by some requests last summer for some numbers of TB infection in a population from a media outlet that caused some stir within the state and within the Department of Health here that led us to, we understood that there was a national push to start looking at making this reportable. It just kind of sped up our process of making this reportable. So like I said, we've been having these numbers of patients that were seen at the health department since 2013, and now it's just adding some additional information from those tested in the private sector.
I think it's really interesting. Just, I have to ask this question, then we're going to finish up. So I find it very interesting that the way you did the reporting is that PPDs, anybody who had a positive PPD, if you're a pediatric, and positive IGRAs for adults, do you think that decision in any way may influence what doctors may prescribe? Meaning, if they wanted to try to get, I know it sounds really my diabolical sense, but I guess what you were trying to do is encourage IGRA testing, which is good. But do you think that maybe that may encourage some people not to get IGRA testing and do PPDs, or vice versa?
Well, my preference would be that they do the IGRA testing because it would be easier on them because their IGRAs are sent to an outside lab, right. And it's more likely that that outside lab has the capability to do electronic reporting to our state. So it would make it much easier on them because that lab would come directly to us. As it's required by the lab to report that information. And plus I think it's a whole lot easier to capture that information in an electronic medical record. That's been some of the concerns that have been expressed to us as we've talked to outside providers, particularly larger hospitals that may see more children, that it varies where a skin test placement and result is in an electronic medical record, and it's more difficult to get that information out to provide a report, whereas an IGRA test is a lab. You order a lab, and the result, it comes back in the lab portion of an electronic medical record. So it's a whole lot easier for that information to be extracted from the medical record and provided to the state.
Jason, that's a great explanation and another angle that I really didn't think about, which is really important. So thank you for sharing that. Well, I know we have more questions, but it's time to go, as they say. I really want to thank, first of all, Christine and Zimi from two different perspectives. One, obviously, thank you for being part of today's webinar and sharing your findings, but more importantly, thank you for everything you do for the CDC, and please extend our thanks to the rest of your colleagues at the CDC for, as always, providing the leadership and putting out these numbers and trends, so this way it gives us a target and a leadership role where we need to go. And then I really want to thank Tom, I want to thank Jason, I want to thank Jenny for sharing their state's experiences and what's going on. I can't thank you enough for great presentations, and as always, the only way we're really going to go forward is if we do this together. This is a team, and that's what makes me most proud about World TB Day and being part of the TB family, is that it gives us opportunities to get together and really try our best to see what is each one of us doing, what are we learning, and where do we need to go. So I want to thank you for doing that today.